Good morning and welcome to Manager Module 4. We are going to start on time and end early. Those are the two goals that we've got so that Tim has a few minutes to swap out and get ready for the second session. So you'll get Latrell and I to start the day, Tim afterwards. It's going to be super fun. We saved the best for last. That's why Latrell and I go first. So we've already been through a session together, and I think you guys guinea pigged me the first time I did the last session too. So I'm sorry that you get the first dry run through, but you get the most off-the-cuff comments and inappropriate remarks. So thanks for that. Everybody should know Latrell and I. Latrell is our director over all of our clinics and soon to be some of our crisis programs. And so she's super excited to have all of that. And I'm our associate executive director and happy to be giving her a bunch of crisis programs. I've been babysitting for a hot second. I would like to say that I'm a little sad to be losing Yolanda, but Raven will be easy for me to part with. So she's ready. I'm trying to get her amped up so that we can have a little more fun today. We're going to start off actually with a group activity. Everybody loves group activities, icebreakers, and things like that. But one of the things we kind of talked about was we've released the core values. You guys have seen core values come out. We've talked about it, but we haven't really talked about how to use them and implement them or have any time for you guys to plan around that. And I know in your day-to-day work that the last thing that you're thinking about is how can I work core values into a supervision or a group staffing or those kinds of things, right? And so if we don't allow for it in time in presentations or training opportunities like this, you guys are just not going to have the time because you're worried about when's the next referral coming in? What fire am I putting out? Am I going to get this CRIS report taken care of? All these things that pop up in your day-to-day time, you don't have time to plan all that stuff. So most of you are working managers, supervisors, administrators, etc. So we're going to work through some of those things and give you some time to do it together. And the best way to learn, honestly, is with some partners because you can share some ideas, you can talk through things, and you can embarrass yourselves in front of us and not in front of all your staff, which is a much better thing to do. I personally don't mind being embarrassed in front of anybody. And that's actually my role as a dad. So if there's a couple other dads out there, our job is to embarrass our children and ourselves as much as we possibly can. I imagine nobody had memorized all of our core values yet, but looking at this class, you guys probably did. You're overachievers. Values posted up here. What we're going to do, I said groups of 3 to 4, but we don't have that many people in here. So I'm going to say groups of 2 is what we're going to do. We're going to partner up groups of 2. And I want you to craft a supervision discussion on one core value. And so what I'm going to ask you guys to do is first get into groups and then tell me which core value, because I don't want to double up on any of them. Because I want all of us to hear, because we're going to present then back a little bit of that supervision discussion. And so just as a quick modeling for you, foresight. If we used foresight as a core value that we're going to talk about in supervision, and let's say that I am overseeing our Bridges Crisis Stay Unit for kids. I might talk to my staff around, hey, how are we planning ahead on what this child's going to need after discharge? What are some of the things that are going on that we know about the history for this child and what their natural support system is and all of that? And I'm going to try to forecast some of what that child's treatment needs are. And I'm going to be thinking about my discharge planning and the follow-up that child's going to need to stay stable and never come back to see me again. You know, that's what sometimes we want to work ourselves out of a job here at Western Taiwan. And the way we do that is by better planning and forecasting and supporting people in less restrictive services. So I'm going to plan and anticipate how that child needs are going to happen. I might also talk about, well, what's DBHDS going to expect of me if I'm operating Bridges? And how that applies to all of my staff, because my staff sometimes don't get that connection. Even sometimes I don't, as a manager, get that connection because I'm so worried about putting a CRIS report in, right? So I might have to talk to them about, well, DBHDS, all they really care about is, do we have kids in bed? They don't care if the kid is the craziest kid in the world. Did we put the kid in the bed and did we fill the bed? And they don't care about the fact that I have 3 people out with COVID that can't come to work. They care about, did I put somebody in the bed? So I have to forecast that and think about how do I plan for those changes, for those needs, to make sure my program operates on par with where it's expected to be. All right. So those are actually all conversations that Yolanda and I have already had about some things, and we've already had that. So that's why it's an easy, supervision topic that I could bring up with anybody. So you guys are going to do the same. It doesn't have to be super complex. This should be on your staff's level. And it's just an opportunity to work these things in that we think are really important for our staff to do and make it meaningful. That's the goal. Make it meaningful, like it's not just words on a page, but it's something that we operationalize. And we do this every day and we just don't realize it and put the words to it. Okay? So, partner up. So here's what we're gonna do. Those of you that just walked in, I had everybody divided out into groups and they were working on a supervision plan that incorporates our core values into supervision with our staff. And essentially just an opportunity, because we don't always have time to like think about this kind of level of stuff. And so sometimes this can just become a paper or something that's written in an email and it doesn't become any practical part. Well, the only way that core values help us craft the culture at Western Tidewater is if we actually implement them and talk about them and make them real for our people. And so I know that our lives as working managers are really busy and we don't always get a chance to think about that. So I'm giving the opportunity here as a part of what we're doing today. So every group had a core value and we're going to go around and they're going to give us a quick presentation on how they would operationalize or make something real to their staff about one of these core values. And I'm just going to go around the room, so I'm not going to pick on anybody in particular, but I want to start with Aisha over here. And we're going to do results driven. So you guys are going to introduce yourselves to the group, and then you're going to talk about what your supervision idea would be and how you're going to make it practical.
And just our names, not our program, right?
Correct. Okay. Just quick, because we're going to try to be done with this in 15 minutes.
Okay. I am Aisha Perry.
I'm Kendra Robinson.
Kendra and I had results driven, which was kind of pretty much right up our alley, especially in my program because it's data driven. Our case supervision would look like, first we would look at realistic goals. How do we get to achieving measurable outcomes? Because you gotta make sure that these goals can be achieved. You can't give somebody off the wall goal, expect them to make it, and they're not, to meet their goal. That's just impossible. Look at we ensure proper training for the staff. Kendra teams go through a specific training. My team as well. Time management. That's what we all struggle with. Just helping your staff to maintain, get what they need to get done within a timely manner to not be like overwhelmed. Impact of time for staff, like any type of interruption, I'll let you.
Yeah, residential, we have a lot of staffing issues. So just making sure that we have enough staff to complete those goals that we talked about.
Review strengths and weaknesses. I know on my end, every 4 months, my program gets a, from the state, data driven that shows where the weaknesses is and where the strengths are. And that's my opportunity to work on the weaknesses to make them a strength as well.
And we also have internal audits that we use to, that we refer to.
Consult with our staff, also with our, director, just to see, which leads to the plan of action, like, how are we going to improve our results and what area we kind of struggle with.
I love it. Great job, guys. So you put results driven at the core, and then you talked about all the things that we're already doing, right? That support being results driven. So it's making this concept. It's not being results driven. Isn't like a crazy off the wall idea. It's something that we do all the time. But we're talking about how we're already practically operationalizing it, and people get meaning to the activities that we do. Then why do we have audits? Because we want our charts and everything to look really good, and we want to have better care. And then that way, when Medicaid comes, they don't find the problems that we've had. We have internal audits for that. So I love the way that you guys kind of brought it to the center, talked about our existing practical ideas, and just made it operational for your group. Excellent work.
Thank you.
All right, resourcefulness. You talked to Don. Resourcefulness.
Morning, everybody. My name is Eric Elam. I'm one of the managers in residential.
Good morning, I'm Jamie Mason.
So our thing was resourcefulness, and so one of the things we wanted to get staff to understand, as far as reaching the community and finding activities that fit the needs of our consumers, because at the end of the day, it's about making them happy. So sitting down with them, figure out what community activities that we could do. Some of our staff have skill sets are better than others, so we're trying to reach everybody out where they are and figure out who has the greatest skill sets to meet those needs of person, then we want to make sure that we are thinking outside of the box, exploring opportunities for the client, because, in residential, they do the same thing every day, so it's just taking time to evaluate one another, say, hey, what can we do today that's different, you know what I'm saying, we're talking to the client, seeing what makes them happy, and then incorporate it, a calendar and how it's looked at.
What kind of resources are you aware of in the community? What connections do you have that we may be able to link our individuals to? Because it is all about making them happy and giving them a life close to what ours is as it's possible, and making them true members of their community.
Yeah, great job, guys. All right, so again, you guys did a great job of the practicality of thinking about resourcefulness, right? Resourcefulness requires creativity, and it requires there to be really no bad option. So when you're talking about what's best for the client, you know, so Brandon, intellectually disabled, some behavior problems, his wife could tell you all about it, and he decides that he wants to be a lawyer. I can't tell Brandon that he can't be a lawyer, even though I know that it's going to be very difficult for him to achieve those things. How are we practically supporting him in the life that he wants to try to do and pursue, and allow him the dignity of success and failure and all of that? And so by talking about that and being person-centered, that helps us to expand our resourcefulness. And then we're talking with other staff, right? So just that normal collegial conversation with people that allows for idea sharing. And so that's part of why we're doing what we're doing today, is because this gives you guys ideas to then take back and talk about directly with your staff. Excellent. All right, we got Elizabeth and Virgil back there with some well-being.
We chose well-being. I saw well-being. I thought it was really important because I was looking at it as we need to take care of the well-being of ourselves as mental health employees, and we take care of our clients, and it's really important to take care of ourselves. So that's why I was looking at it as well-being. So we were talking about checking on the status of our employees and observing them, and then showing concern and empathy and asking how they're feeling, how we as supervisors can assist them. And when they are when we're talking to them, ask why are they feeling that way, and then recommending EAP. And then some of the programs that we offer, which are the Zumba to address personal health, Wellness Wednesdays, and then our if they didn't feel comfortable with the EAP, our insurance from Western Tidewater also provides therapy. And then the other things, we're practicing self-care. And then if we can, like, maybe look at their leave and see if we can manage it, maybe encourage them to utilize some of their leave if they feel they need it, or maybe if we feel that they might need to take some leave as well.
We're applying the same rule with, as we observe consumers when we're in front of them as well. We have to observe our employees because, body gesture, facial expression, things of that nature, we need to be conscious of that. The same way that we observe consumers, we need to observe our employees because they may need assistance, just not asking for it. So, we have to be concerned and mindful of that as well. So, as Elizabeth stated, there's certain things that Western Tidewater offers to assist their employees. Just picking back off like the Zumba, the Wellness Wednesdays, things of that nature. And if you see that you need to reach out a little bit more, we can utilize the insurance as well to step outside, because sometimes people is not comfortable talking within the agency, so they may need to go out to an outside resource.
Yeah, I love it. Again, practically identifying the things that we already do that support well-being. And I love that you guys are trying to model for your staff by keeping out an eye out for your staff in the same way we would want them to keep an eye out for our clients. And it's amazing how much of a difference starting a conversation with a staff or a supervision that says, hey, how did that thing go that we talked about last week? Your kid had a college football game. How did it go? Your spouse is recovering from a surgery. How are they doing? How are they feeling? Some of those practical conversations that talk about, I know you're more than just who you are here. And it's amazing the difference that it makes in people's lives when you do that. The same thing with our clients. We're just role modeling everybody here as a person. They're not just a thing. And then, I hear sometimes well-being Western Highwater don't care about me. Well, if we didn't care about you, we wouldn't do Zumba and Wellness Wednesdays and have a lot of the fringe benefits and those kind of things. We care very much about our employees. We can't go give everybody a hug like we would like to, maybe on National Hug Day or things like that. But we do care. I know you guys care about your staff and your employees, and as managers, we are a reflection, or the agency reflects us and the way that we work with folks. And so demonstrating that caring nature, you're then reflecting on the rest of the agency's the perception of the rest of the agency when you do that as a manager. That's part of your job and part of your role. And it's one that sometimes we don't talk a lot about because it's like one of those side things that's not, you're not reviewing a productivity report or filling out some paperwork or doing an evaluation, but that's one of the things that you do. All right, great. I'm gonna keep us moving because I'm talking too much when you guys should be talking. All right. What did you guys have?
We had outreach.
Outreach.
Oh, no, they gotta do theirs for homework. They came in too late.
gotcha.
You guys had outreach? All right, great. Introduce yourselves and tell us about outreach.
I'm Lori, dance point program manager of the CCBHC.
I'm Lana D'Ambrosio. I'm the program manager for Waverly Nursing Home Pilot without a name.
She takes care of people in a nursing home and makes sure they don't act out and go back to the state hospital, right?
Yes.
I want to point out that the people that go to the Waverly Nursing Home are individuals that have been in and out of the state hospital system for their lives in most cases. And they have a 0% readmission rate from that nursing home because of the supports that are provided, the collaboration we have with YAB. That is definitely something to clap about because that doesn't happen anywhere else in the state of Virginia.
I'm Amy Baker and I'm the nurse manager at Bridges CCSU.
All right, let's see what you got, ladies.
Since we were all late, we had to hurry up to come up with something,
We have 3 minutes.
so outreach kind of was, I was like, okay, well, this makes me think of my program right now because like I shared with them, we don't have any individuals right now, so instantly I thought about, outreach and / marketing, that's instantly what I thought about. And just like what supervision looks like right now for us, like you said, the practical things, the things we're already doing, I would be making the staff, whoever I'm having the one-on-one supervision with, I would be, of course, reiterating, making them aware of the things that the agency already has in place in terms of outreach marketing, and kind of then put it on them in terms of their ideas and how they think they could everybody has their strong points, their weak points, whatever, but like how they could offer to outreach / marketing. Like I talked about with you guys, us being a 24-hour program, everybody ultimately rotates weekends. So the weekends is normally when, just different little community events take place or whatnot. So, that supervision would look like giving them what we, reiterating what the agency already offers and then allowing them to give me their feedback in terms of how they would like to contribute and offer their support in terms of outreach and marketing. And then just go from there and kind of provide whatever, materials, resources, really just help that go into effect.
And with outreach, you can also, like the suicide prevention walk is coming up. So it's just something in normal conversation you can talk about with people. Lots of people, I've seen people out in the community with suicide prevention t-shirts on. And so you could say, hey, we're having a walk, why don't you come? And so just generally talking to people out in the community lots of times, even just when people ask me, what do I do? And I start telling them, and I can't tell you how many people have said, you do great work with, people with dementia. A lot of people don't have the patience. And if there's one thing this lady knows, she's always told me, you've got such a lot of patience. And really, I don't. I just trick her.
She just puts up with drills, what she's saying. She just knows how to tolerate it.
Well, and for us, I know that a lot of times, Raven can attest to this. We are in Hampton and the people 5 minutes down the road from us don't even know that we're there, or they feel that the referral process is so overwhelming, they don't even know where to start. So, taking that time like we plan to do to just actually go and show the process, you know, to make people aware, like, hey, this is what we do, we're here for you. Group homes as well, you know, there is a lack of awareness.
And to piggyback off of what they said, what we can do also is we can kind of see what our budget offers, and then.
What are you talking about money? He said nothing about money.
I'm going somewhere with that. So I'm going somewhere with that. So when
We
we
just
do
forgot
our
that, we left that for her, to talk about the finance.
so when we do our outreach, we find the areas where it's most needed, and we go to these places to try to pull them in. We always can take them something. You know, everybody loves something. So we can take them something to kind of bribe them a little bit, to come on and hear a little bit more of what we have to say. So that's our outreach field.
That would be swag. And
And a smile.
And did y'all know that swag, it actually stands for something we all get? That's what that word's from.
No.
Yeah, that's what swag is. Something we all get. And that's why, you know, so when you put all your stuff out, it's something that we all get, right? That's what swag is. That's how that started. Great job, ladies. Yeah, I don't think we have to. Yeah, outreach, I think that's all really great stuff. I really love talking to staff about their responsibility as being outreach. And we forget sometimes that we're all community members. None of us live on another planet, right? We might not live in the Western Tidewater catchment area, but we all live around here, right? We all interact in our communities, at the grocery store, things like that. At church, look, everybody that has got a mental health problem or has a crazy cousin, I get that. That's what I get at church. And it's okay. I love it. Like, cause there's nothing, to me, that's actually one of the reasons I stayed at Western Tidewater for so long, is because we've made an impact in our community. There's a program now for Bob's crazy cousin, right? Like, those are the things. I go to church with the deputy chief of police from Franklin, and we talk all the time about the people that they interact with in Franklin. And we try to plan, and we have community relationships. That's outreach. It's just relationships, it's outreach, it's marketing, it's communicating about what services we have, because people don't know. We don't have a PR firm that manages all of our marketing. Us, our staff, knowing how to talk about our agency is huge. It's the biggest thing that we can do. Oh, where do you work? Western Talk. What? At the jail? No. We provide mental health, substance use, and developmental services for people. And what that probably means to you is, you know, your cousin that had a problem in school and was always struggling with getting good grades and all that. We might be able to support them with finding a job. We might be able to help somebody that when they're feeling suicidal, we can help them in a moment of crisis. So knowing how to talk about what we do and why we do it is important.
And talk to your staff about it so they as well can do the same that you're doing.
Yep.
In a positive.
Yes.
Yeah. Yeah. I mean, it depends on if you're on the first year of the conversation or the fifth. But everybody's got workplace struggles. You know, there's always frustration in the world. We work with imperfect people, right? But being able to highlight the things that are good about what we do and what our intention and our mission is kind of how you drive that home. So I can complain to somebody about Latrill in the same breath as saying Western Tidewater is a really good thing, right? And Latrill can complain about Brandon and definitely still talk about why Western Tidewater is a good thing. But what I know is the people we work with, no matter how much they frustrate you, you will not find a group of people more dedicated to taking care of people that need help than the people that we work with at Western Tidewater. And I tell that to everybody. Doesn't matter how much somebody frustrates me with they didn't do one thing right or whatever. We work with caring people that want to do good things. And so that's a reflection of you guys. Make sure that your staff are in the right place and doing the right things. All right, I'm going to skip you two because you really got distracted. Unless you came up with something really good.
We came up with something.
Over to you.
This part is 100%. No, we turn back.
No, they lost 20 points by coming in late. So yeah.
All right, I'm Kia Edwards. I'm the program manager with Jira.
I'm Fedora Johnson. I'm a clinical supervisor for the CBI and Neuro program. That way, really.
We had determination, and that's basically committed to achieving our goals. But we think back to how we work with our clients when we start treatment planning.
for them to buy in, we have to first let them, they have to understand the reason and purpose of coming into treatment. It's the same way we're working with staff. If they buy into it, they'll be committed to achieving those goals. And in order to do that, they have to feel encouraged and supported. I do check-ins, providing education and resources for them to feel, I guess was the word I'm looking for. Come on, girl. Educated enough to feel comfortable enough to carrying out our goals and our mission, especially with our programs that we have here. And training, education training, maybe some models, but yes, those things are important for us to achieve our goals.
Anything else? As well as finding out what the employee, if they have any external trainings that they would like the opportunities that they would like to attend as well, and support and encouragement to continue to enhance their knowledge of our population and services that we offer within Western Tyler and how they can apply it to our clients.
And also identifying their strengths and their weaknesses and how we can accommodate them, or help out, because I might be good in one area and Medora's not, and we can work together to maximize their goal.
Great. Yeah, that's great. And determination is important here, right? Like, y'all ever get stuck into that thing? Like, I don't see anybody getting any better, like right in front of me. And you got to know how to push through, and you got to help staff push through that because they get frustrated with it. And so goal setting, goal attainment, celebration of goals, really, really important. So why do we send out an email when somebody gets some kind of new licensure or all that kind of stuff? They worked hard, right? And so celebrating those things with your staff, those accomplishments, the training, getting through a training, a certification, all those kind of things, you did something, you achieved something. Same thing with our consumers. We're celebrating, and that helps to keep people motivated, keep their eyes fixed on something that you said. Great job, ladies. Good job. Really well. All right, troublemakers.
So correct. We have to disclaim. So we have a little skit real quick.
First of all, I'm Rachel Carlette. I'm the nursing manager at the CCBHC Crisis Therapy.
Yolanda Daniel, program manager for Bridges. Desired folks. What am I? The QA manager for DD and ID waiver case management.
Yeah, all right.
I'm ready.
All right. Look, I gotta go pick up my 6 kids. Raven don't never come on time. Sit down, Sally. Raven don't never come on time. I'm tired of working late. I had to do all the referrals by myself, all the clinicals by myself. She need to get here on time. I don't know why she can't never get here. Always.
Hey, Sally. How did everything go today?
You were late, and you're coming here with Duncan.
I mean, I was already gonna be late, so.
See, that's what I'm talking about. That's what I'm talking about right here. When she is late, it messes up the whole flow of the unit. I don't have time to keep doing this.
Okay, ladies.
I gotta go pick my 6 kids up.
Okay, ladies. Definitely we need to talk about this, but we're not gonna talk about this right now. Everybody is already on 10. We don't want to get to 100, so I will talk to you before the next shift starts, okay?
Never get it anything.
With next year.
I don't have my gun.
Sally with discharge.
Okay.
And I'm 10 minutes early today. Good
Mm.
morning.
Mm.
Hey, how are you?
Good morning.
Are y'all ready to have this conversation? Yes, ma'am. How are you doing this morning?
She get here on time.
Are you blessed and highly favored?
I am.
Oh,
Yeah,
yeah.
you know,
And how are you?
I'm wonderful.
All right, ladies. So this is how we're gonna do this. I'm gonna talk, you're gonna talk, and you're gonna talk. What we're not gonna do is talk at the same time. Can we agree on that?
Yes.
All right.
Yes.
So what I hear is going on is that sometimes you are late. And we understand that sometimes everyone can be late, but what we need to be is accountable for what we do. Is that correct?
You
Can we agree on that?
times last week.
So that last week,
Excuse me,
talking about
excuse me,
yesterday.
ladies, we're not doing that, correct?
You're right.
All right.
Correct, I'm sorry.
I'm taking accountability for my
About time.
We're gonna give her grace, right? We're gonna give her grace. What do you think that you can do differently so that this doesn't happen again?
Well, number one, I can start making sure that I'm getting home a little earlier because I know how the traffic is, and I like to get done on my way to work. And I can also just make sure I'm doing my role. I did hear her say something about she had to do opportunity work yesterday, and that's not fair to her. I'll make sure that today and moving forward, I'll split the work with you. I'll do the notes for the clients, things like that.
Also, maybe give her a call, give me a call,
Sure.
let us know you may be running a few minutes late, because maybe I can come in and conversation, go and do what you need to do, and I'll discuss with you when you get there.
Yes, ma'am.
For what we can do different. Okay, are you feeling a little bit better about it?
Yes, I am. Now that I know she's gonna take accountability, and I am too. Cause I didn't have to come in upset like that. I had some things going on already.
And we appreciate that. So what we also discussed back there is that a part of accountability also included integrity and respect. If you don't have any integrity in your work, you're not gonna do your work well. And if you don't have any mutual respect for your counterparts, you're also not gonna do your work well. So we marry those concepts to help people understand it. To be accountable, you have to think about how you wanna be seen, how you're presented to people, and how people represent themselves to you in that environment.
I want to point out two things about that. One, is that you could do that skit in front of your staff and use the skit as a tool. Or you can use it as a practical supervision as the skit played out, because those things happen in our programs, right? No doubt. So both really great, really encompass what accountability is about, that we all as a team succeed. So forward together is our tagline. That doesn't just mean with clients, it means literally working together. And so I insert forward together sometimes as a joke, just because I can be corny and I can be like, remember, we're moving forward together. But there's some real stuff to that, that honestly, I can't move forward if Gloria and Raven aren't doing their role at the CTH, right? Like literally, I'm not there every day. All I can do is give guidance, and that's the time I've got, right? Like I can talk to them, I can staff the case, I can do that, but I can't move forward without those two doing their job and doing it really well and setting an example at the CTH. The same way all of you guys are at all of it. We're all connected to one another, and so that accountability means we're dependent on everybody else in our team to be able to move forward. So that's a great example of how to do accountability in either way, whether you're doing it actually as the supervision or as a skit with your staff. So good, really good work, guys. This is the stuff that we're after to try to think about how do you include it in your supervision. It's not any different than the things you're already talking about with them. It's planting that there's actually a word tied to that from our core values, okay? And I would encourage you all to try to do that, especially in group supervision or in some of your planned formal individual supervision. Okay? And ladies, why don't you introduce yourself, since we didn't skip you, but you can at least say.
Hello, I'm Shayla. I'm the dietary manager at the home.
Shayla.
And I'm with one of the nurse managers.
And we all know why they're late now. They work at the go. And they were being accountable probably to their individuals at the go. So thank you, ladies, very much. And for letting me pick on you a little bit too. So don't be afraid to put this up somewhere. I have this, but at my workstation, this is posted on my wall. And it reminds me that I'm supposed to do something with it. Put on the backdrop of your computer, things like that. This is a tool. This isn't just something we came up with. This should be a tool that you use to help shape culture, behavior, thoughts, actions of staff. All right. Now we're going to get into the boring stuff. I'm going to apologize. You're going to get some history, and I'm going to try to be quick. But the words, well, before I start on all of this, who can tell me if they know what STEP Virginia or CCBHC are? You're in the right class today then. All right, good. So STEP Virginia and CCBHC is what we're going to talk about for the remainder of the time, but we're going to relate it to the governor's Right Help Right Now initiatives, because all these things kind of work together to create the behavioral health system we're currently in. And I know some of you are in DE residential. Don't think this doesn't apply to you, because it's all interrelated. It's all part of how our system works, is governed and operates. We're not going to dive too much into the specific services and steps. You guys can read that stuff, but we're going to talk about the why, so that you have a better understanding, a better picture of the influences that we experience from the outside that impact us on the inside, and why we've done a lot of the things that we've done. So in 2023, Demetrius released a strategic plan, called it One Vision, One Mission. We had experienced rapid growth. Any of you that have been here for a few years know that from like 2017 to 2022, we went from probably about 300 to 400. Now we're at 800 staff. We're huge. We are in the top 5 CSBs in the state of Virginia in terms of size of staff and budget.
And when I came here, we were
one of the smallest CSPs.
We were in the bottom 10 and we are in the top 5. That's how much explosive growth we've had. Now, some of that's great and some of it's a major pain in the butt. Like, I know it causes people stress. I know it causes people, heartache. And a lot of us have jobs in this room because we've had a lot of that growth. And a lot of our staff have jobs because of that. And we have a lot more services available to our clients than we used to. But that doesn't mean it didn't come out without some growing pains. So the very first thing that we knew we needed to work on was we had to have some increased accountability on the performance contract. I'm going to talk more about why as we go through some of this, but that meant that we needed to strengthen departments like quality assurance, human resources, finance, and IT. Business development that I'm in charge of is another place that we basically grew from nothing and said we need to keep an eye on these things, and that's what keeps us honest with the people that send us money. Because if there's one thing that need to know about money, it's if you get it, you need to keep getting it so you can keep paying the bills. We needed to enhance our customer service experience. As we had grown, it's hard to keep in touch with your community and with your clients. Right? Like you could bring in a bunch of new faces, you lose a little bit of your identity, some of those kind of things. So Trill and I are old school folks, and we did prevention a lot when we were here. And so we were out in the housing communities, we were working directly on the streets with people, we were having community events, all this kind of stuff. And we lost a little bit of that because we were so focused on trying to stand up and build new programs. And so we knew we needed to really enhance how we were looking at that. So that means same day access got stronger, meaning that people got to care quicker. It meant that we have more peer services, an expanded category of a whole new employee that people had lived experience and knew how to engage folks. And we're trying to get rid of barriers to program access. There was a time and place when to get into a CSB, you sat on a wait list for 30 days before somebody called you for a screening. And then if you're lucky, you got another appointment in 30 days. That's 60 days. Who wants to go to treatment 60 days later? We're not even talking about like getting referred to a specialist. That's like that get into your PCP, right? All right, and then we had to enhance our responsiveness to our community needs. So, if I've got police calling me and saying, I don't even know that you guys exist. What are you doing for all your people? We're dealing with all this mess on the outside. If I've got schools saying, hey, we got a lot of kids that need help, all of that. So we worked on the way that we do this. We had to have some specialized supports. You guys don't ever do anything with people with dementia. Yes, we do. You don't do anything with people with TBI. Yes, we do. And how are we having partnerships with parenting groups, with our FAPs, with our DSS, with all these community stakeholders? We knew we needed to reemphasize this. So if you look at what our prevention team now is compared to what it had shrunk to, we've significantly grown prevention and community stakeholder services, and we tied it to every one of our clinics. And that was a strategic move. If every clinic serves as the locus for that community to contact, then everybody knows what building to go to, what administrator, what all of those things are, so that they can get the care and the response that they need. And then those clinics are then responsible for making sure all the rest of that linkage and support happens, okay? So that when the deputy chief of police has a problem in Franklin, I tell him to call Brittany Johnson and to get it figured out in Franklin, right? Like she knows who that person is. That's the kind of place that we're going, and it improves our service promotion. So you guys talked about outreach, right? All of us have a responsibility by connecting to our communities and doing an outreach. So our communications plan, all of that work that we've done with Beth coming in, and we've rebranded some website stuff, and you'll see some more communications planning coming to the program level throughout the year. A lot of that is promoting and talking about our services internally and externally. Why do I say internally when we're talking about supporting our communities? Because we're all a part of the community. And like, if we didn't know that Aisha ran FFT, how would we ever know that when that person comes up and says, my kid's really getting in a lot of trouble in court, and I think it's because he's probably smoking weed, and I just don't know how to take care of him at home and all of that kind of stuff. Well, you know what? A justice-involved youth with maybe a little bit of substance abuse and things like that, functional family therapy is going to help us get back to the way that we can work as a family and understand how we support one another and how we can get our family dynamics into a place where at least we can keep them out of jail. And then we can be working on the rest of the mental health or SA needs later on. All right. Oh, you'll notice that this is about the same time period. 2023, Right Help Right Now got released by Governor Youngkin. So something that you guys need to be aware of is politicians find things that are good issues to talk about. And you know what? Mental health is something that crosses party lines. So I don't care if you're a Republican, an independent, or a Democrat in this room, mental health matters to everybody. And it's an easy thing to talk about with any political party. It gets you a lot of votes if you can figure out a way to do something with it. And so Governor Youngkin said, I'm gonna latch onto this and we're gonna figure out a way to get care to people. Now, he was experiencing a lot of things. Law enforcement's overwhelmed, hospital bed shortage, things that are impacting emergency departments, all of those kind of things. There's a lot of attention at this time period, and still today on this. But he released a whole bunch of money. It was also under, a couple of audits and things like that. I'm gonna get that in just a second. But know that this came in about that same time. So there's a lot of attention in the DBHDS state government world on what we're doing with behavioral health. So they set 3 really simple goals, I think, which we know does not, as behavioral health employees and developmental services employees, we know this doesn't even touch the surface of what needs to happen to take care of everybody in Virginia, right? But it's a really good start when you're talking about things that are already underway, and he's leveraging it. That's what Right Help Right Now did, is leveraged other initiatives. And so this was what this is what the 3-year goals are. These are the achievable SMART goals. They're measurable and all of that. So we talked about goal setting, right? Public mobile crisis teams, they started at 36. By the end of year 3, we want to get to 140. We're in year 2 right now, is where we're at. Now, I can tell you, we manage 105 private providers in just our region right now that provide mobile crisis response services. Tim has set out, well, they say they provide it. We manage probably 15 that actually do the work. Tim sent out all the MOUs for us, and so I've signed every one of those MOUs with every one of those private providers. Your inbox gets really full whenever that happens, but there's a lot of people across the state that are doing this work. It's lucrative, it's good money if you can find the people to do it, and you can do it the right way. A lot of people fraudulently do this too, but we'll talk about that in the training. Crisis receiving centers. Do you guys remember when urgent care centers became a thing? Urgent care and primary care became a thing. You didn't have to go to the emergency department anymore when you had strep throat. You could just go to an urgent care, get your antibiotic, and go home. That's what crisis receiving centers are. That's why we have a crisis receiving center. We're going to make our crisis receiving center a part of our community, whether I die trying or not, right? That is going to succeed because people need a place to walk into that's not an ED. We need a place to walk into that when you have a behavioral health problem, you can go get behavioral health treatment. And that you don't have to go to the hospital as the only alternative. We can start you on some medication. We can provide you with wraparound support. We can love on you and take care of you and keep you in your home, hopefully.
And what we need from you guys, and to share this with your staff as well, is when, even in your community, your church, to push the crisis receiving center. Picture just like you go to patient first when you can't get an appointment with your doctor. We need you guys for this to be successful. We need your word of mouth that is here. And it's that simple. If you're experiencing a crisis, it can be mild. Give me an example of a mild crisis, somebody.
Losing a loved one.
We can serve you. Give me another one.
Divorce.
We can serve you. Push it. Push it. That's what it's here for. And if we do not get any people in here, we would not be here for the community. So we have to make this happen, and we need you guys to make it happen.
And let's destigmatize crisis a little bit. Crisis doesn't mean that you have to be psychotic, naked, walking down the street, playing your kids. Okay? Crisis means I'm having a situational moment that I could use some intervention. Okay? One of the places we'll be pushing a lot of marketing is really with our local colleges and universities. There's a lot of kids that when they go off to college, they're struggling with a whole lot of things and they need help and support. Doesn't always mean they need a pill, but they need somebody to talk to and they need a place to find that support and help. So anyways, I'm going to get lost on that if I could go off too long. But we were the first one started in all of Region 5. We were one of the first 3 in the state. We are 24/7. We're changing that building. We're doing modifications. Maybe someday the city of Suffolk will approve it. But you can see we're building out those beds. Again, this gets people out of emergency departments. Have you ever gone to an emergency room? Does it make you feel crazy just being there when you're sane? It does me. I hate it. Like there's noise, there's lights, the people come in. I don't know.
Out the door, keep opening, closing.
I don't know who the last person I talked to. There was a student, there was a nurse, there was a care partner, then there was a doctor, and then I'm not sure if the doctor was really a doctor or just a student. And
then they send you back out to wait some more.
Yeah.
Short-term crisis beds. So this is crisis stay beds, up to 2 weeks of care. At our CTH, we technically will do up to 30. We prefer not to, those kinds of things. But in Region 5, we used to have 3 crisis stay units, 3 for adults. We have 1 right now, and they're operating on a limited capacity. So there's 10 beds available for all of Region 5 for crisis stay. That's why we're building it.
I have no question. So, if I could be, reach the full, would I be able to tell our parents if they can take their loved ones to the crisis receiving center?
Yes.
Good question.
Yeah, absolutely. That's open to anybody. It doesn't matter. So yes, so if a developmentally disabled individual, Reach maybe can't quite serve them. We just talked about this morning actually with Raven. Can't we get them there to get a medical screening or help us fill out the Reach paperwork or some of that kind of stuff? Yes, we can do all of those things. And if anybody tells you differently, call. Yes, Raven.
I know this is off topic for one topic. I just think it's really good too, like y'all talk about with networking and like with referring people, when they get to the CRC and you see that you're hitting your 24-hour mark and it's not working and they need more help, please refer them to us if they have an ID, please, because our beds are so empty. You know, like,
Good work. Good marketing. I like it. Good internal
Good
communications.
outreach.
Yeah. So yeah, absolutely. And then I'm going to hit just this last one. This is the most amazing thing that's ever happened in the state of Virginia.
Yes, it is.
Priority 1 waiver slots being assigned to people. You know, waiver's always been referred to as the golden ticket, right? And there's a lot of need out there. There was a waiting list years long. Jamie, you've worked with families forever. There was probably families that were priority 1 that waited for as long as their kids were kids and then into their adulthood, right? And might never have gotten that waiver slot had this stuff not happened. So the DOJ came. The DOJ is a major pain in our behind. They make us do a lot of stuff to report to them and show that we're making progress. But that accountability that they caused led to the state appropriating funds for more waiver slots. Those waiver slots are directly helping people. And now you know what our problem is? We actually got so much money in waiver slots, we don't have enough providers to provide the services to all the individuals that need the help. So behavior consultation, that's a really good one that it's hard to find a behavioral consultant to do these things. So his help right now included some of this work that was already happening with funding waivers. So in Western Tidewater terms, what the hell does right help right now mean? It meant 2 things at the time, and we're going to talk about how that changes a little bit. But it meant all this 988 crisis work that you've probably heard about. You can call 988, get the National Suicide Prevention Lifeline. They talk to you, and in the state of Virginia, we linked services directly out of that center, and they then dispatch mobile crisis teams to respond to somebody. They give local supports. So there was all that. So the Crisis Now model included somewhere to call, somebody to respond, and a place to go. Okay? Those 3 things, when you're in a crisis, are really important. And it's least intrusive to most intrusive, right? I'm talking to somebody on the phone, helping to de-escalate them. Like 90% of the calls to 988 get handled right there. They never need anything else. And it might just be a situational. I'm grieving. I'm having a tough day at work, those kinds of things. That next 10% ends up with maybe a mobile crisis response somewhere. And then the last one, maybe that wasn't enough. Maybe we needed somewhere to go to get out of our environment for a hot second and maybe calm down. The parents were the ones that were aggravating me, so I left. Those kind of things. And these are all less intrusive, though, than an acute hospitalization or being placed under an ECO and having my civil liberties taken away if I get TDO'd. God forbid I get arrested, and then I go to jail, and then I can't sit for trial because I need to be restored. So I have to go to the state hospital for 90 days for a misdemeanor crime that I committed by stealing a Mountain Dew. And I spend 4 months in jail for something that would have been a fine, and I got released from jail the next day had I been sane, right? And then CCBHC, Certified Community Behavioral Health Clinics. So this is a national framework that basically says, if you took a CSB and you looked at it anywhere in the state, and you said, what makes the best CSB, or in the country, what makes the best CSBs? It has a bunch of clinical services that are wrapped around it. You use evidence-based practices because we know that the work we're doing is going to yield results. It's been studied and understood. You're going to get people into care quickly, same-day access. You're gonna take care of veterans, people that get sometimes overlooked because, you know what, veterans are sometimes a little salty. And you have to think about how to have good military cultural competence. You guys have had to take that training probably. You have to know how to interact with them. You have to have peer services, people with lived experience that have been through this, informing your processes. That's what CCBHC is all about, is these things. We're gonna get more in depth into the specific services as we go, but it's a model that says, if you do this, your community is well taken care of. And that's what a CSB is all about. Don't have to do all the services yourself. You can contract with other people. They're called a DCO, a collaborating organization that provides a service on your behalf, that you work with them and share data about patients. Okay, so that's what Help Right Now meant for us. Money was gonna come out to achieve these two things. Then we found out all those cool things about CCBHC, the state was working, we were organized, we had all kinds of initiatives, we were meeting about it, and we were like, yes, we're gonna have a prospective payment system that pays for our care, we don't have to worry about billing. So I guess I gotta tell you guys, fee for service is what we do right now. Every time a client comes in, we bill them for that encounter, right? Just like a doctor. So whether you have a crisis stay bed day or you have a outpatient visit, we bill fee for service. CCBHC comes with a prospective payment model, which means that you tell the Medicaid entity, it's going to cost us $5 to take care of Latrell in the community. And I get $5 to take care of Latrell in the community for the whole year. And if I do really good and it actually only costs me $4.50, I get to keep the extra 50 cents on Latrell. But if it's somebody like Brandon that's more intensive and I have to spend $5.50 on Brandon, then it's a wash. And so I do cost reporting to that Medicaid entity. They set a rate for me, and I take care of the people that walk through my door. That's prospective payment. And so this was great. It was going to be a way to transform how we could get this, and we leverage Medicaid dollars instead of state dollars. So if you guys aren't familiar with Medicaid and federal dollars, we get 50 cents and only have to pay the other 50 cents to make the dollar when we get Medicaid money. So the federal government pays half, Virginia pays half. When it's all General Assembly funded, Virginia pays all, right? And so if you wanted to cost share some expenses at your house, you would want to invite the federal government to come pay that 50 cents. Well, in true fashion, our government said, we can't do that right now. And honestly, it was a lot of competing pressures. Medicaid was doing a re-procurement with their MCOs. And so what that meant is they were selecting new health plans, and they were too overwhelmed to come up with the prospective payment, do all the legwork that comes with that. It's understandable. It really is a huge shift, and you have to do it right. DBHGS was pushing hard with us. They lost the battle, and Virginia said, we're going to pump the brakes. And we just can't do this right now. It's the second time we've tried to do CCBHC in Virginia, by the way. The first time was in 2008 that we failed. All right. But we're not done yet. Because what we said instead was we're going to reemphasize this thing called Step Virginia, which really came out of our first attempt at trying to build out CCBHCs and the government saying, oh my God, we have not enough money to do this. They did a whole study. They saw how many millions of dollars it was going to cost, and there was just no way to write that check at that time, right? And so they said, well, we'll do with a Virginia model instead. We'll try to get some of this stuff started. We'll be building toward a future, but we can't put all that money into it. So that's what they did. Step Virginia got made. So we started. First service up was same-day access, and that was combined with primary care screening. We'll talk about all these steps here in a second. And we decided we'd build out a network across the CSBs of getting some of these collaborative services together. All right, and that's what it was about. It was Virginia's way to say, we're going to buy into the evidence of CCBHC, but we can't write the whole check today. It's like our responsibility for foresight is to see this and say, what do we have to do at Western Tidewater to be ready to support this, right? That's our job as directors, administrators, managers, supervisors. And how do we organize our agency to do that? And so you'll see parallels to a lot of the service changes and things like that we've had over the last, what are we now? Almost 6 years in. And the state had to set goals for all of these. They've semi-succeeded in some of that. We'll talk about dashboards. But anyways, that's That was the plan. We did get a little bit of money for each one of these steps. In some cases, like psych rehab, I think we got $30,000. Now, look, I would love for somebody to write me a check for $30,000 if you want to do it in here. But in terms of operating the agency, that don't even buy me a staff, right? So $30,000 buys me like a half a case manager. Okay, so it's not a lot. Now, same day access got more money. Primary care screening did not get hardly any. Outpatient got some more money, but outpatient was one of the better funded steps when you exclude crisis, and I think we got $300,000. I don't know if you guys have gone shopping for licensed clinicians. $300,000 buys you 3 people.
Yeah.
And maybe their laptops. Okay, so, but look, that is part of our mission, right? It's not like you weren't doing outpatient before. It helped us to expand and look at fidelity and all that kind of stuff. So why do I bring up Step Virginia and CCBHC together? Well, I bet Latrell could come up and draw a line between any of the core services from CCBHC on this graphic, and we can find where they match over here. So crisis services. Oh, you got it. There's a crisis service. Look at that. Screening, diagnosis, and risk assessment. Man, that sounds a lot like psychiatric rehabilitation services. Outpatient primary care screening and monitoring. Targeted case management. Care and family services. Community-based mental health care for veterans. That sounds like person and family centered treatment planning. That just sounds like all of it. Outpatient mental health and substance use services. Now, the one thing that's not on this graphic that is down on this one is this, care coordination.
Let's challenge them, Brandon. Let's see if they know what that is. What's the difference?
Yeah.
What's the difference in this one? For sure, maybe 2 different people are being paid for the same thing, like.
Yeah, so you're not duplicating services. You're making sure that they're getting the service that they need at the right time. Yep.
Some more?
I look at coordination as like every instance, like different avenues. One,
You sound like you worked here a long time.
I know, right?
Exactly right, Aisha.
I was taught well.
Yeah, absolutely. So, yeah, coordinating how the whole person's taken care of, right? Our targeted case management often has to look at pieces of that, but they may not be as involved in directly arranging transportation, even though sometimes our case managers get sucked into that. May not be as deeply involved in primary care. So sometimes we have a really blurry line between case management and care coordination because there is nobody else. But I want you guys to ask yourselves, what's service access at Western Tidewater?
Access to all the services that we provide.
Yep. We have a team that handles an internal referral and moves them to the appropriate medically necessary service. Sometimes it works good. Sometimes it needs help. You know, it's something we made from scratch, right? What about anybody know what central scheduling does in our agency? Doesn't that sound like coordinating somebody's care? We have a transportation department. They make sure people get from their house to the service they need. That's care coordination. So all of these things are stuff that CSBs do already. It's enhancing the work that we do. And JLARC, which is the Joint Legislative Affairs Review Committee, I believe, they basically are a watchdog. They go out and they look for problems and then they say, these are the things you should do to get better. And the Behavioral Health Commission, better known as the Deeds Commission, you guys know Senator Deeds' son committed suicide and attempted to kill Senator Deeds in the midst of a behavioral health crisis. That led to a lot of the reforms that we see today, like your 8-hour ECO coverage, and if you can't street anybody, basically. That used to be a practice. If you couldn't find a hospital bed, well, good luck, right? Now it's you can't release somebody. They have to be committed to the state hospital if you can't find another accepting bed. And even if the state hospital doesn't have a bed, the person can't leave. Okay. So that all came out of Deed's legislation, but the Behavioral Health Commission, they're meeting today, by the way. I'm gonna have to sit through a wonderful, boring session that they talk about how bad CSBs are, focused on this stuff. And so this is what needs to happen. And so they reprioritized CCBHC into Step Virginia. They're investing in Step Virginia. We're gonna eventually get to CCBHC. It
And
might
we'll be ready.
Yeah, yes, ma'am.
Okay, so theoretically speaking, I have a family that lives maybe out in rural Franklin. They need to get some supportive services. They don't have any services for us yet. Are they able to get in contact with me the same day access and work with their coordination to get them transportation out the same day access so they can start getting services?
Yeah, that's a good question. And I would say yes. So I'd say it's not our routine to get the, to do that because, and same day access has a day in Franklin at their Franklin Center. So that makes transportation less of an issue. If that came up, I think we could coordinate that work. But what I would tell you is I need you to probably talk to Courtney, who is our administrator over same day access, to try to walk through the logistics if they really can't get in for that first time. And we need to set the transportation up.
So more of a direct question. I'm sorry, I just always have a question.
No, it's good.
So in real life, I have a family that does not have transportation, so they're always missing meetings. Would they be able to connect with care coordination and maybe make it to the day support to participate in a meeting, a planning meeting or something like that for the person that they're responsible for?
Yes, I think our case managers should be linking through transportation and make sure that we handle the care coordination aspect of their treatment. Yes, absolutely. Those are the resourcefulness things that we need to talk about. So it's saying I have an identified problem. I know these people aren't purposefully missing it, but they've got a barrier. And so how do I rectify that barrier? And what resources do we have internally or maybe externally that we can use to meet that need? So yes, we should be having conversation with, maybe it's on a route that we're already driving, or maybe we can have a transportation driver do that as a Medicaid taxi service, which Latrell has pushed pretty hard to be able to drive that Franklin and get that in for an appointment on that day.
And if you run into a barrier, just ask for the next higher up.
Until you get to Latrell.
Just keep going through that list first.
All right, so you guys get it, how similar they are? Almost identical, right? I'm not going to read all of that. I'm going to send you this PowerPoint when we're done. You're going to have it. These are the boring definitions of each one of the steps. Okay. What we are going to do real quick is just talk about a little bit about it. So same day access, also known as SDA, means you can walk in and get your assessment and get linked to services that day. You don't need an appointment. And better than that, we should have you seen for your first appointment in 10 days from that intake if you are found to require services. We do that pretty darn well here, thanks to all of you making sure there's capacity and things like that in your programs to serve people. And we're going to talk about dashboarding in a little bit, but we lead the state in this one. Primary care screening is really just two simple things. You get your height, weight, and blood pressure when you come in for an intake assessment. All right, and all that means is that we identify a risk factor. So if my BMI is, 32, they're going to say you should probably talk to your doctor about lupus. Why don't you go talk to your primary care physician, make sure you got access. Your blood pressure is 185 over 110. You got some cardiac risk factors. You need to go see a doctor probably quicker than not, right? And then people that are on antipsychotic medications, doing a metabolic syndrome screening. So that our psychiatric providers are always recommending that we check somebody's blood sugar, cholesterol, those kind of things, because antipsychotics drive up the risk of all those metabolic disorders. That's all it's about. It's really simple. We click a couple boxes on some assessments. We report out what we do, but more importantly, we're coordinating that person's care, getting them and treating them like a whole person. Did you know that a person with serious mental illness dies 25 years sooner than the average person?
Thanks.
So a person with schizophrenia is likely to die 25 years sooner than a person with the same health risk factors that does not have schizophrenia. 25 years, a lot of stuff happened in 25 years. I started here 19 years ago. I was a school-based clinician 19 years ago. you chopped off my 25 years, I lost all of my college and all of my work here at West Pawtucket. That's not something I want for my people. We changed that by doing this. Okay. And you guys can imagine why, right? Like, I don't want to lose the why. If you're hearing voices and you're delusional and you can't keep track of the things that are going on, how can you go to your primary care appointments without some help and guidance and support? That's not what I'm thinking about. I'm thinking about the fact that somebody just
somebody shut up in my head. Yeah.
I'm just, I would piggyback on that and say it's not only that, some of the medications that you're given for, some of these diagnoses cause health conditions, and if you're not.
Not a attorney.
Yeah.
You're regular doctor, you would.
That's true.
Yep. 100%.
The stress, like
Yeah.
the stress in the body is crazy.
Corticosteroid levels in your brain from repeated. So I don't know if you guys know about first episode psychosis. Talk to Deborah Hall sometime. But the repeated crisis, take some high dose of antipsychotics, go off my meds, crisis, high dose of antipsychotics, etc. The corticosteroid levels in the brain cause permanent damage, which is why you see individuals lose cognitive function the older they get with psychosis. And that's why first episode of psychosis treatment focuses on low dose antipsychotics and engagement of somebody. You ever have a 20-year-old? Do they ever think anything's wrong with them?
No.
I can't be sick. Think about somebody telling you you're psychotic at 20, and if you'd listen to them, I wouldn't. All right, outpatient services. I gotta focus. Outpatient services. That's just really simple. We see people for outpatient therapy, and we operate with evidence-based practices. Latrell, can you tell us a little bit about like what DeMera is working on regionally, and like what required evidence-based practices we've got?
So I know we get a lot of emails, right? But I need you to pay attention to the email that come out either from DeMera or from, what does it say on there when Alex
Either
said
was
it?
Region 5.
Region 5 training.
Region 5.
Those trainings, you guys, those emails, those are trainings for you to be even more proficient in the outpatient therapy, even more proficient in you being the clinician and the manager who's leading staff and guiding staff with supervision. So outpatient services now have responsible for the training here at the agency. So if you can recall, we sent out internal one for case management, we sent out for documentation writing. In addition to that, we sent out training for CBITS. Turnout was not, we did not participate. We sent out motivation interviewing. Those are things that when Brandon gets to the additional slides are required. So these trainings we're sending out are very important, and they will enhance your clinical skills. But please look out for them. The next one coming up should be CCBHC. That's a big one.
There was 6 extra letters in there. Solution focused group therapy.
WWTCCTE, SFBT.
You got it.
So I'm asking you guys to pay attention so you can assign your staff and yourself to attend. These are trainings that only will make you better and smarter. And we're doing first time since I've been here in 20 years that we pushed out so many internal trainings. So that's my spiel on this. And I want to add also too, when we're going through the Step Virginia, I think we have an additional slide. It's required training that go with it. Okay, so keep that in mind when you see those emails.
And I hit on like solution focused brief therapy. Any one of you can apply that. You don't have to be a clinician to use solution focused brief therapy. There's going to be a training that's going to be virtual. You should go. Find the time to do it. That one is good for staff. It's good for your clients. You can teach those techniques to any of your people that work for you. I don't care if you have DSPs working for you. A DSP can use some of these strategies to be more successful.
And you can use it with your own children at home.
So, anyways, encourage, find time, do it. All right. Crisis services. Crisis services in Step Virginia focus mostly on mobile crisis. And this is where we have received a ton of dollars, but it's because we do it for all 9 CSBs. Like we manage our RC5, our REACH services, all of that come out of mobile crisis. We respond in hours to anybody experiencing behavioral health crisis. I like to brag whenever we have good things and we leave the state, we have a 45-minute response time on average. Only Only region in the state that's under an hour.
You guys, from Western Power lead a lot of things, and that's why Brandon and I are so excited to talk to you guys about things. We want you to feel what we feel and hear. You guys, it's all because of you guys.
Yeah.
So, I previously worked at another CSB, and when I started there, we had a reach person at our CSB. Is there a reason that the reach was taken out of each individual CSB?
Yeah, because they didn't ever serve anybody in Christchurch. I mean, I say that, it sounds terrible, but think about one person to cover an entire CSB. Can they be available at midnight?
Yeah. Well, I don't know, maybe I misunderstood, because what we were told there, maybe it's all about training. We were told we don't to that person for referral purposes, and then that person reached out, and they were the ones that coordinated that service.
The model never showed any effectiveness in actually mitigating crisis for individuals with developmental needs. I think that's really what it was about. And so Hampton had reach at that point. Hampton ultimately bowed out. And that was because they were really struggling to keep the CTH going. They were really struggling to keep mobile crisis. They couldn't get clinicians, all of that kind of stuff. We were dumb enough to say, sure, we'll take it. In 2017, we took all of it and we dealt with all the headaches. I mean, like, honestly, boards calling and saying, well, we used to have a person sitting in our office right there. Could you just please pick up the phone and call me? Because what I'm going to do is I'm actually going to respond at midnight when the person's freaking out and running down the street. And that's what it was about. And could you just call me, because I'm going to actually admit the person to the CTH. I'm not going to have a phone conversation with them and convince them they don't want to come see me. Like, those things were all important changes that had to happen. And I'm going to tell you, we're still not perfect. Lori doesn't have anybody at the CTH right now. I'm really disappointed in her, because she should have some clients admitted to the CTH. But the whole state had to relook at that model, because reach was actually basically homegrown in Virginia. And there's some good research out there that shows all the data we have, and they've presented nationally about reach services across the state of Virginia. People still get frustrated with us because we haven't fixed all of the world's problems yet. We'll get there eventually. So peer and family, again, this was about getting people trained, certified, and registered as peer supporters. And that means that you leverage your lived experience. It doesn't mean that you can't be a college graduate with an advanced degree and actually know all this stuff, but you still have lived experience. We've got veterans that we leverage their lived experience as veterans. That's important. Military, again, this was led by Brandy Jankaitis, who's now the director of Department of Veteran Services for the state of Virginia. She was at DVHDS, and she worked with a few of us at the CSB level to create this step. And it's probably the most impactful step in terms of objectives that we've had that reached all the people in CSBs. We focused on military cultural competency training. We all have to take that module. That was never required before. It focused on screening clients to determine their military status, because what we know is if we identify a veteran, we know they're at a higher risk, and then we screen them with a Columbia Suicide Severity Rating Scales, we decrease veteran suicide. Numbers vary depending on what year and who you talk to, but 20 to 25 veterans die a day by suicide. We don't want that to happen. These are folks that dedicated themselves to protecting us. All right? And if we know if we do this, it decreases veteran suicide, we can get to a place where we stop it. CSBs didn't do this before. So not only did we say that we were going to do this for veterans, but we actually agreed as CSBs we would screen everybody with a Columbia. Case management, we know what case management is. This was just to provide high quality services, and it included us making sure that we were doing it well. Psych rehab, we want to think about psychosocial PSR, right? That's all Virgil's thinking about. But this really encompasses skill building.
It's so funny because it's probably true.
Skill building, mental health skill building type of stuff. ACT services fall into this kind of a category. Anything that is around a rehabilitation part of our work. Okay. And last, care coordination we're going to talk about, so I'm not going to spend a ton of time there. All right. So we did set Virginia phase 2. Because everything comes in phases in Virginia. We got to make it sound cool, like we're doing something better. All right. So started back all the way in October of 23, and you can see our little timeline. And so they did site visits we had Brandon Edwards from DBHDS come and jump into one of our directors meetings, I think, was where he came. And so he's a representative from STAC, which is the Step Virginia Advisory Committee. The people that basically tell us what we need to do as CSBs for Step Virginia. And I highlighted this because we just submitted this last week, Step Virginia cost report. You remember I talked about prospective payment model? Well, they use the CCBHC cost report that helps you determine a rate that you get paid for CCBHC services. That's what we use to provide a report back to the General Assembly on how much it costs to actually deliver these services and how much more money is needed to build out an entire system that's based on this. Why do you guys care about that? Well, at least we're getting practice in doing these cost reports, and people are starting to get used to looking at true cost of delivering care. Now, what I think happened here is that there's going to be a whole lot of apples, oranges, grapefruits, tomatoes, and cucumbers that DBHDS has to look through to figure it out, because the guidance was a little sketchy. But we all got something in an initiative, and they have information to look at as a system if we're smart. We'll do a good job at looking at that and make it a better process. And the General Assembly will get information about how much money they need to figure out to pony, right? They'll realize how much better it would be if the federal government paid 50% of that. They're supposed to finalize performance measures for us in December. I think that's not likely to happen because we're slow. And I'm part of the reason we're slow. I chair our data management committee for the BACSB. So every time that you have to do something like a Columbia suicide risk screening, or you have to put in an element about somebody's military status, every one of those elements has been reviewed by our data management committee. And so I don't let DBHDS ask you for anything without me, or our committee, not really me, look at it and say, we're okay with capturing that information and it makes sense to do it. Now, some things we don't really like, but we are forced into it because the General Assembly told DBHDS they had to get it, like peer staff classification. That's why we've got all those specialized peer services in our EHR. The only reason those exist is so that we can report on Step Virginia peer step. Good news, I think that's going away next year. All right. Stuff you can read later. JLARC's recommendations, General Assembly wanting us to do stuff with behavioral or with CCBHC and Step Virginia. General Assembly wants us to have appropriation language that says that DBHDS must monitor our performance contract closer. There's a 100-page document-ish that governs what DBHDS expects from us as a CSB to get money. Most of you guys are blissfully unaware of that stupid performance contract. I am not. I have a team of people that has to try to keep track of that. Namely, Morgan Pusillo helps me out with most of our performance contract things, but prior to Morgan, Andrew and I used to have to keep all that stuff in our head, and Heather, and make sure that we're meeting those guidelines. The increased accountability here comes down to monitoring, are we delivering what we say we will deliver? So whenever I've got a new QA audit, whenever we've got a utilization review of your programs, whenever we've got these things, it's because DBHDS is looking closer at our books and making sure we do the things they want us to do. And why do they care about beds at Bridges? Because they have 16 beds for all of the acute stays at the state hospital at CCCA. 16 beds for all the kids in Virginia. 16. 16, guys. So they've got to keep kids out of the state hospital. The only way they do that is they send them to Yolanda.
So when you were talking to your staff and you or your administrators on you guys about notes, documentation, is not only to protect you, right, and the client to have their record. The information in there help us get the data and information that we have to report to the big brothers.
Yep. It's just accountability is all it is. Boils down to accountability. That's why it's one of our core values. We have to be accountable to others. Our staff need to be accountable for their jobs. All right. I'm running really low on time, but I am going to pull this up. And the link to this will be in our PowerPoint slides. I'm going to ask you right now, please feel free to click on the link. Please don't share that link like outside the agency. And I only say that because this is a draft. Like it's publicly published, but they haven't really released it. This is DBHDS is doing. There's a lot of great information about CSBs in here. Really, honestly, I'm going to focus on outcomes, but there's a whole bunch of information about our CSB profiles, what our catchment area looks like, the population, all these kind of things that people don't really understand. It's going to be really great when it gets launched publicly. some of it's still a little broken. All right, so that's what it looks like full size. And what I'm going to do is I'm going to go to the program outcomes. Blah, blah, blah. Okay. So you see this thing on the side here where it lists all the CSPs? You probably can't read it from back there, but I promise they're all there. The great thing about being Western Tidewater is we're always at the bottom, so nobody ever sees this when it first pops up. Okay, so this is just measures and saying whether we met, we're within 10% or we haven't met it. So Columbia suicide risk screening for kids and adults, target met. We're good. This is the one that ticked me off. Says we don't offer same-day access. I'll show you why it ticked me off in a minute when I show you the other dashboard. Because we leave the state. So this was, they recorded information about our service availability and they recorded it wrong. And I've been fighting with them for the last 3 months to fix it because quite obviously you see our same-day access data and we have it. And we're not only meeting, but we're leading. And then SUD engagement's another measure. What we know about substance addicted individuals is that engaging them early on in care with a certain frequency of service ensures that they complete treatment or increases the likelihood they'll complete treatment. So if I only see them once in 30 days, it's not likely they're going to stay engaged in treatment and get sober. However, if I see them 2, 3, 4 times in the first 90 days, I like double my chance of them successfully completing treatment just by being available and making sure we have that frequency of care. There's some other cool stuff with scatter plots and all that. I could spend a whole day talking to you guys about this. I just wanted you to know this is going to be published for the public to look at. So when we do measures and we click buttons in our EHR, like for Columbia, it means that the public then gets to see if we're doing our job. That's increased accountability again. Okay. Now, while I'm here, I'm also going to go to this. Now, this one I can't share with you because this is on a restricted site. What's published up here is our actual performance on those things that I showed you. So it'll actually show our numbers of how many people got a Columbia suicide risk screen, how many people got a same-day access assessment taken care of, how often did they get linked to services in 10 days, how many times did it take up to 30 days for them to get in service, how many took longer than 30 days, how many never re-engaged, all those kind of things. And they do that by our state data submission. They can see we code an assessment as a same-day access appointment. Then they see the next service that's delivered, outpatient, case management, anywhere. And they look at those two and they just do a simple calculation. And while I'm on that, just for your information, right now we submit our state data on a monthly basis. Get it scrubbed by Shannon and the staff on the Credible team. You guys probably have gotten nasty grams like, you can't have a pregnant 45-year-old male. Please fix your data. We have the opportunity to scrub and make it look pretty.
Well, maybe.
We're replacing might have a gender identity as a 45-year-old male, however, a biological male, which is what we record in the gender field right now. So they we submit that, we get it to clean it up before we send it. CCS is gone after this year. We're replacing CCS, which is our state data reporting. We're doing transactional reporting. So when a service is submitted in Credible, that night CCBHC will get it.
So bizarre.
So there will be no more data? Data reporting?
It should be going away. Actually, yes, we're getting very close in reach.
Oh, okay.
I don't know that the replacement of CCS fixes that, but VCC build out fixes that for me. But that night, DVHCS has access to what we did. Now that doesn't mean we can't correct it, right? Like if we find that somebody clicked the wrong button, we can edit the service, they send a repeat message, blah, blah, blah. It also solves a major problem we have in Virginia. There's no way to identify that Lana D'Ambrosio that we served in Suffolk, Virginia on September 9th of 2024 is the same one that got admitted to the hospital in Richmond on June 6th of 2024. We can't do that. There's no master patient identifier because we don't send enough information right now that DBHDS can make sense of that. So there's no way to link a state hospital admission to a CSB client.
Even with
So
like.
you're saying like
birthdays and-
it will all communicate?
It won't.
It does not now. It will
It
starting in
will
July
though,
of next
like all communicate, you'll be able to see all
Okay.
that.
What about like the socials?
year. We don't send a social security number. We send a hashed social, which means that we basically encrypt it. So you can never link it and identify back, but the hashing that's done here doesn't match what the state hospital has at Eastern State.
What happened
So-
time is on? Wait.
What?
Not that.
So now we're gonna be able to tell and see how patients flow through our system, see how they get services at different places. I guess this thing is not gonna work, so I'm sorry.
Yeah.
And you guys are getting a break before the next one come up.
Yep.
You're bringing it so boring.
I can tell that you guys are bored to that.
Granny getting all of this data.
Yep, I'm trying to be quicker. So move through that, you already saw that. There we go. That's what the site I was trying to pull up looks like. So you can see we got same day access. We got a benchmark of goal of 86. Right now, the CSB system's at 73. Western Tidewater's at 98. Same day access. 98% of our people are there. They at 83.9% for people that get their appointment within 10 days. And that's compared to a state average of 81.5 and the goal of 70. So don't tell me we don't offer same day access. All right. Columbia, same things. We are at 90%. The state average is 74, goals 86. Okay. All right, cool. That's all the slides. So a couple of quick takeaways that I want you guys to make sure that we leave here with. One, business changes happen for a reason, even when you can't always draw a clear connection. So ask, Brandon, why the hell are we doing this service? It's okay to say that. And we can either say, what? You know, I don't really know why. That seems stupid. We could probably do that easier. Or it might be because we're being asked to be held accountable by somebody, and now we're doing it. So, you know, Yolanda is asking me the question of why do I have to put in SharePoint, this state data thing that I turn in once a month to DBHDS? Well, it's because I have to have somebody on my team look at it every single day and report back to Demetrius how we're doing on census numbers. So the business decisions that we make here are all related to external and internal pressures on it. And if they don't get tied back to that, then we should stop doing it. And so sometimes asking the question means we stop doing it because there's no reason, right? So it's important to ask that and try to understand. It's also important to talk to our staff about increased accountability because we're accountable first. And this is the way I always ask people to think about it. If you've worked for me, you've gotten this lecture, the first person we're accountable to is the person we're serving. Okay? And our job is to take care of them first, foremost, and everything else. Our second accountability is to our agency. And our agency needs to know that we're doing the work that we've promised that we would do. We've accepted money.
So you can't take somebody money, don't do the work.
And we've said we will do this. You may not like what we promised we would do. I may not like what we promised we would do to get the money. Sometimes we have to make compromises and say, okay, well, if that's what you really want, but I can still do this other thing, then we'll do it. The third level of accountability we've got is to ourselves and to our staff. And that we need to make sure that we're taking care of what those other needs are. Now, I put agency and client first in that because if we're not doing them, then we're not really accountable to ourselves anymore.
That's right.
Because we're not doing the work we take a paycheck for. So keep those things in mind. Make it practical for your people. They are caught up in day-to-day work. It's easy to be blinded to the bigger vision. Help them celebrate some of the success. Help them see some of the change that's happened. Talk to them about the impact we make in the community. It's bigger than where they just sit. It doesn't have to be a long point of supervision, but talk to them and relay that. And if you don't know, then you should ask. You should bother me. Bother Latrill. Get answers from us about why, so that we can how can you explain it to your people? We owe that to you. That's our level of accountability. Latrell.
I think it's nothing left. All I want you guys to do is take the information and please share it. You guys lead your department, lead it by sharing the same information, same knowledge you receive. Because sometimes they, like Brandon mentioned, that they get so tired of the day to day and also get tired of the negativity. Bring it back home. Bring it back for them. We're doing this. Yeah, I'm sick of doing the no. Yes, Missy sent 10 emails about the red X. But you know why we need the red X now, right? Now you know all the why. It's told to you today, and this is what we need you to explain to your staff, that we don't just it's not about the money, it's about accountability. And then the money, those who come from under me, about the money.
What questions do y'all have?
So seeing our numbers, how are our numbers comparing to other CSBs, and more importantly, when are we gonna get from this DOJ implementation?
Great question. Great question. It depends on the numbers you look at. We're really good at some things, and we've got areas that we could probably improve on. I think one of the areas we particularly struggle in is, like if you think about DOJ, is around employment discussions, which is a hard thing to do. Sometimes as a case manager, to have an employment discussion with a family when their individual or when their child or whoever they're caring for might never have a job, and we can see that the functional capacity of the individual, their total care, and they might never work, but we still have to have that employment discussion and check a box. So that's one of the areas that we struggle in. So, but in general, we meet most of our benchmarks. We are generally above average compared to other CSBs. We are one of the top CSBs in terms of revenue collection. That's one of the reasons we push it so hard, because that's what helps pay everybody's checks. That's why we have so many services that other CSBs don't. It's why we manage 40 extra exhibits to the performance contract and extra funding pools. It's because not only do we take DBHS's money, but we then go and bill and support the service without having to get their money in some cases. So when you ask the question, how do we do in terms of other CSBs? We're generally in the top half in pretty much everything. I think we have good, hardworking people. There's some areas we could be better at. The DOJ. The last court hearing that the state had with the DOJ was basically a joint request for relief from the remaining elements that we had to satisfy in the settlement agreement. To say that we're working on these, we have established systems and protocols, and the judge has not yet ruled all the way, but the DOJ and Virginia are in agreement on kind of what they want to do. And so we are probably within a year of the DOJ going away, but that doesn't change what we've got to do. Like, we still have to maintain the services, supports, the data monitoring, things like that. What might go away is the DOJ independent reviewer looking at something every, quarter with us and choosing different services to audit. So we're close. If you pay attention at the state level, Heather Norton led the majority of our DD work related to the DOJ. Heather Norton was just recently appointed as the deputy commissioner, which means she's got mental health work too. Now, there's some good things and some bad things to that. Heather's a CSB person. And Heather knows how CSBs work, but she's also been very pro-private provider. And so that's not a terrible thing. There's space for all of us, but in some ways, CSBs have a certain level of interaction with DBHDS that ensures we have a standing place. And that's important because the dollars that we get only go barely far enough to do the things that we're doing now. And if you spread that out wider, you don't get as much help. So it's a good question. I think DOJ will be out of our hair soon, and I'm hoping they don't come back for our state hospital system because we're at risk. We have 0 bed capacity. We have a 50-person waiting list to get into a state hospital bed right now on the civil side, and a 50-person waiting list on the forensic side to get in. And other states have been taken to court by the DOJ for those very reasons. If you guys want to talk about that, want to get bored listening to me talk about all the reasons why, we can have a conversation anytime today.
And I just want to add this last part. Since I've been here before, our executive director have always been a person who's ahead of the game. So he can foresee, for some reason, he has that psychic power of where something is going, and we like to be first to dip in there. So that's why a lot of these programs we receive funding for, because we're already setting up for it and then ask for the money. So that is something that we've been, I say blessed. If you're offended, I'm sorry, blessed. Our exec been blessed that we had an ED that can foresee where something is going and we jump ahead of it so we can receive the funding.
And we've also said, sure, we'll do that, and then we'll figure it out later on how we're gonna do it.
Yeah, like Chiro, well, yeah, we do it.
All right. You guys have been an awesome audience. I'm gonna stop talking now because you need a break. Kim's gonna set up. I thank you for everything. Questions and comments are always appreciated afterwards. Email the or myself, or both of us, and tell us if there's something you think we missed or something we could have done better. We want to make this a good training. You're our first group that's gone through, so you'll make it better for everybody else.
Thank you.